Took it out.
Case number 3, 52-year-old recreational athlete presents with an inversion mechanism of right ankle sprain 6 days ago. The injury occurred while jogging in the woods with friends. The patient felt a pop in the lateral ankle and midfoot at the time of injury, was only able to bear weight for a few steps immediately afterward. Though all x-rays were negative for a fracture, his PCP provided bilateral axillary crutches, and was advised to remain non-weight bearing on the involved side until
That's
physical
PT,
therapy,
physical
PT
therapy.
evaluation. No more information about the medical evaluation conducted by his PCP was available.
All right, patient history. What is this diagnosis? Oh, it's a lateral ankle sprain, as the case says. What are typical demographics for this diagnosis?
So the male and female, they're both equal.
You're darn right they're both equal. Oh,
And for the race of blacks, is more than African American and whites. For activity levels, around half of ankle sprain occur during sports such as basketball, football, or soccer. And it could also occur during stepping off a curb into a hole, landing from a jump, and landing on a competitor's foot.
very good. Share with your audience a specific description of what exactly happened. So someone's gonna say what happens during this mode of injury, and someone else will move their ankle in that manner. You do while you're standing.
Yeah.
So we can there you go. All right, you all right? What's first? Let's talk about the forefoot. Forefoot is doing what?
The forefoot will adduct.
A deduction of the forefoot. You could forefoot A deduction. Yeah, rear foot.
It internally rotates, and the ankle
Inversion.
will be inversion and plantar flex.
And
the
hip.
hip will be externally rotated.
Now hit the floor. Boom. You see lateral ankle sprain, right?
Yes.
It doesn't look like that. That's what a dancer looks like. Put it on the floor. Put it on the floor. That's what it looks like.
Oh, but that's plantar, no?
Yes, you're plantar flexed, but you're still like that. You can be plantar. Oh, good. Very good. That's what it looks like. Good. What is the most common ligament injured with this diagnosis? Can I finish my question first? No, I'm joking. What is most? I'm kidding. No, you know, someone was saying, why? Someone was saying, why are you so hard on Kat? I'm like, no. Kat now knows that I'm joking whatever I say. She does not freak out anymore, right, Kat? Are you freaking out now?
Yes.
No, good. It's not. All right. So wait, Kat, what is the most common ligament affected in this diagnosis?
It will be the anterior talar fibular ligament,
And what do I call it?
ATFL.
ATFL. I don't call it that. Everyone calls it that. ATFL, anterior talofibular ligament, ATFL. What percentage would you say of all cases is this one?
75%.
Impressive. Yes, 75%. What's second most?
CFL, which is
Yeah. Calcaneal fibular ligament.
Yes.
And the least sprained ligament or injured ligament?
The posterior talofibular ligament.
Yes, TTFL, good. Okay, so you're also asked by the doctor to assess a DVT. Why is that relevant for a lateral ankle sprain? That makes no sense. Why is a DVT relevant?
A DVT can be caused by, if someone got a lateral ankle sprain, they could be immobilized for a little bit, and that could cause a DVT, blood pooling, not enough muscle contraction. And our telltale signs are pain, heat, redness, and swelling.
Yes, you must, if you have a lateral ankle sprain and the patient has been non-weight bearing, you really must assess the area for heat, swelling, because you don't want a DVT at all. Okay, very good. Now, you want, even though the x-rays were negative, you still want to be safe and rule out fracture. So you are going to invoke the Ottawa rules into your assessment, right, or treatment. So show us on a patient where we palpate for the Ottawa rules, and we want to start with, we'll start with the ankle palpation first. So let's have a patient, let's have a therapist, let's play clinic.
Alright.
All right, so first for the ankle, where are you palpating?
Gonna find the lateral malleolus, and then we're gonna palpate about centimeters
Yeah.
above.
You're gonna find the posterior part of the lateral malleolus and go 6 centimeters up, pushing with your fingers.
Pushing, palpating, see if it's
Excellent,
moving.
excellent. And then you're doing the same thing
Moving
with
on
the
medial
meat.
side,
Correct.
push.
Yeah, so if I have a bad lateral ankle sprain, injuring the lateral malleolus and bone above, right, which is what, the tibia or the fibula, right? That makes perfect sense, right? Because a bad ankle sprain, boom, I could hit the ground with it, it could break, right? Medial makes sense too, because when you do a hard ankle sprain, now you're taking your foot and you're shoving it right into the distal fib, and that could fracture as well. That makes sense so far. Good. Now, how about foot pain? Where do you palpate on the foot?
The navicular bone,
And where else? The navicular bone.
and the fifth metatarsal.
So in the medial side shows that
Medial
every show the
side.
world. You find the navicular tuberosity, right? Which everyone, that's the bump below, right? It's like below and medial to it, right?
Yeah.
I think that's you.
And then
And then the fifth metatarsal head. That's the first metatarsal head.
the fifth.
First metatarsal. I thought you say fifth.
You did.
Oh, fifth metatarsal. Yeah, show us the fifth metatarsal head.
Back here. Right?
The head of the fifth
Yeah.
metatarsal, which, all right, the head of the fifth metatarsal makes sense because a lateral sprain, the fifth metatarsal head is hitting the floor. That makes sense. But the navicular bone, excuse me for saying this, makes no sense to me.
Makes no sense.
It is not being hit when you do a lateral ankle sprain. Not. So what does the navicular bone have anything to do with the Ottawa rules? Are they just a little bit off up there
Yes.
in Canada?
Yes.
I'm
Somebody made a
kidding.
mistake.
Yes. What is going on?
So we have the, God, how do you pronounce it?
Bifurcate.
Bifurcate ligament.
There's actually an R in there, but the
Well,
bifurcate.
there's no T in it.
It's the bifurcate.
Bifurcate ligament, which
Bifurcate.
attaches the calcaneus to the navicular. And,
So there's two parts, right? Calcaneus to navicular and calcaneus to the cuboid muscles,
And the
right?
cuboid.
So the part of the bifurcate ligament that attaches the calcaneus to the navicular,
right,
which is right here. When you do a hard lateral movement, it twists the bifurcate ligament and can actually what?
take it off and take a piece of the bone with
Which is called what?
a avulsion.
Yes, it can actually
Sure.
pop off the navicular bone, taking a piece of the navicular bone with it, which is called an avulsion fracture or, Gus? Or a teardrop fracture. Because the piece of bone that comes off with the ligament looks like a teardrop.
Wheezy.
All right, so the bifurcate ligament is one of the reasons why the navicular bone can be affected. And what's another reason?
The other reason is that the tendon of the tibialis posterior also connects to the navicular, and if that can also pull.
Yeah, a hard lateral movement could pull the tendon of the navicular bone, a tendon of the posterior tib off of the navicular bone, creating an avulsion fracture or a teardrop fracture. Thank you for clearing that up. Now it makes perfect sense to me why you would, yeah, now it makes sense, thank you.
You're welcome.
All right, so any good therapist always checks for edema and properly quantifies it so that when the next therapist works with them, they know if the swelling has gone down or up or what have you. So Yat will show us how to do the figure 8 edema assessment.
So we're gonna go. We're gonna go here to find the antib tendon.
How do we? What's the best way to find the anterior tib tendon?
So,
You resist dorsiflexion and it'll pop right up, right?
Yes.
Excellent. All right, so you
Find
put
it.
there you go. And we're using the centimeter side or the incher side?
Freedom side.
No, not the freedom
Then
side.
find the navicular bone, and you're gonna be right in front of it.
Yes, you feel for the navicular tuberosity. You put
Yes.
the
Take
what is
measure.
it? Tape measure right in front of it, not on it. You're putting it caudal or right in front of it, right?
Okay.
Then you go underneath. Good.
Underneath, and then you find the fifth metatarsal at the head of it.
And you're going right behind
Right
the fifth
behind
metatarsal
it.
head.
Go around, meet up here at the tendon again. Then you're gonna go over or under the medial malleoli.
Let's go over.
Okay, let's go over. Then on the back, you're gonna feel for the soft tissue between the calcaneus and the tendon, the Achilles tendon. You're gonna go under it or at it, and then I'm gonna go again over.
Above the lateral
Up and
malleolus,
above.
you come in the middle,
Yep.
and that's the reading.
And then, boom.
You got it?
Yep.
Good. We provided a video in the module. We have a video here on how to do it.
Goodbye.
Somebody will have to do it for the practical. So know all the bony landmarks, get good at doing it. Someone will have to do it. All right, good. And then you put in the chart. That was what, how many centimeters? 40, it was 44 last time. Uh-oh.
Ooh, it's the other foot.
Okay, good.
Oh, yeah, it is the other side.
All right, good. Now, we're gonna do special tests.
We're gonna
do
put ice on the
the
top.
Taylor tilt first.
We're gonna do special tests to rule in this diagnosis. So the first one is the Taylor tilt. Show us the Taylor tilt.
So we're gonna do the ATFL first, so we're gonna go in plantar flexion
Full plantar
and
flexion
inversion.
and
'cause that's
inversion. And a
gonna
positive
put
sign
that
is what?
pain, or you can feel a lot of movement, 'cause
Right.
that
So
ligament isn't holding it in place.
You must
as it should.
compare the good and the bad side. No
Mhm.
offense to saying good and bad side. But you're looking for increased pain or excessive translation or movements, right? That's specific to the ATFL. That's the number one ligament affected. Number two ligament affected, you said was what?
CFL, so we're gonna
CFL. So how do we
put
test for the CFL?
anatomical position and do the same thing.
So no full inversion, plantar flexion,
Mhm.
just at rest, and
Yep.
you do the same thing inversion,
Mhm.
and the positive signs are similar.
Same.
Good. What's another special test?
And that was done. We have to get our
Anterior draw. Wow, patient becomes therapist like
Yeah.
that. That's a quick turnover.
So we're gonna hold the keys, and we're just gonna put our hand on top of the joint, and then we're just gonna pull.
Yes, you're holding onto the calcaneus and you're drawing anteriorly. Again, looking for symptoms of pain or excessive translation
And at the same
when the compared to the good and bad leg, right? But what if the patient really is inflamed? If they have all that edema, you could have a false negative because the edema could stop excessive translation. So what do we do?
So we're gonna have the patient put their foot on the towel, and this time we're just gonna stabilize the foot, and we're gonna push posteriorly.
So now you're pushing posteriorly on the distal tib fib, right? And if you have excessive translation that way, then that will be a positive sign.
Yeah.
Very good. All right, very good. All right. Now, do you have any differential diagnosis? Oh yes. So we're going to talk quickly about a high ankle sprain versus a lateral ankle sprain. What is the mode of injury? First of all, what's the mode of injury for a high ankle sprain?
You've got it right.
Oh, right there.
here.
Okay, next question. How
So
about you
there's
tell us anyway?
No ankles, there's no swelling, first of all.
No
You
swelling.
have external rotation, dorsiflexion on the talus on the distal tib fib.
So external dorsiflexion and external rotation of the talus of the distal tib fib, right? So it's like something like this, right? And what does that do? That separates. There's a ligament between the distal tib,
As
tib and
opposed to
fib,
this.
and that separates
This
it.
is the lateral.
You
and
should
then
definitely know the
this is
difference, right?
This one.
External rotation on the talus on the distal tib fib. Hematoma and swelling are not as common, right, as opposed to lateral ankle sprain, which is much more common. Good, but you guys are so thorough. and he's thorough. You guys are so thorough that you are going to do a special test
Yes.
just to rule out high ankle sprain,
Mhm.
though clearly it's not based on the patient's
Yes.
explanation.
This is the fibular translation one, so I'm gonna have you lay sideline, and I'm just gonna support here, and basically what I'm doing is I'm moving the fibula,
So yeah, you're doing this.
side to side.
You're taking the fibula,
Mhm.
fibula, and you're going that way and that way.
Mhm.
And if there is a sprain in the middle, that patient will feel discomfort or even excessive translation. Very good. So now, as another benchmark to see how the patient's doing, you decide to do a balance test for this patient. Now realize, if you have a really bad ankle sprain, please do not in the clinic tell the patient, oh, Dr. Dan said we're gonna do a balance test. If they cannot weight bear and they're in a lot of pain, you don't do this now. Does that make sense? But let's assume this patient can do it.
Now,
Oh, there's one
your
more thing for the
tension-
Agua rule, by the way, you didn't mention, sorry, is that they cannot walk 4 steps.
Oh, yes.
If a patient was like, cannot walk because of pain, that's something to be worried about. All right, this is the STAR excursion. Do you see Carlos's name and my name on there?
Yeah.
Look at that. All right, so what foot is affected for this patient?
It is the right foot.
The right foot. All right, so the patient has no shoes and we're gonna say no
No
socks.
socks.
Don't tell Dr. whoever that in this class you can walk around barefoot.
All right, Elena, so you're gonna stand on your right foot.
Okay.
You can balance any way that you need to, and what you're gonna do is just touch each of the lines
Okay.
and touch, come back to center, touch.
Now, when you say touch, you mean like toe
Just
touch?
tap,
Toe
toe
touch,
touch.
yes.
Yeah, toe touch, there.
Wait, that is anterior, that is anterior medial, right? It's
Right.
medial based on the patient's foot. That is straight up medial, you got it?
Medial, yeah.
And then
That's
this is the one
posterior medial.
that would
Go.
hurt them out.
Dan, right? Oh, I didn't do that on purpose.
Yes, you did.
Posterior, good. Posterior lateral, go behind you, straight up lateral, and then anterior lateral. You got it? Those are the movements. So my next question, which one is the hardest on the patient?
It is
This
the
one.
posterior.
The Dan is the hardest one.
Dan is also.
Now, why is that?
Because it's putting the most stress on the lateral side of the foot.
That is right.
It's
And when
having-
is the test considered null and you have to start over? If the patient does what? If they put too much weight, they cannot
Go
balance,
like this.
yes, then it's considered a null test. Very good. So posterior medial is the hardest one. Yes, of course, there's a question probably on the exam about posterior medial.
On the quiz?
Quiz, exam,
Clinical question for the.
for sure, for sure. I mean, I'm guessing, I'm saying. All right,
100%.
all right. Range of motion testing, which again, you'll need goniometry, and manual muscle testing, which again, you'll have to manual muscle test, like you've done in kinesiology. What is range of motion testing gonna show? Range of motion, well, what?
Decreased in dorsiflexion, plantar flexion, inversion, eversion.
General range of motion issues, because they're swelling at the knee,
And
right?
pain
And what about weakness?
everywhere.
Yes, they have general weakness and general range of motion issues because of what happened. Also, you might find an antalgic gait, of course. Good. Now, before we go into treatment, tell me about the 3 grades of sprain for this diagnosis. Grade 1.
You've got light damage, and for special tests, you're gonna have probably a negative for all of them. Mild edema, not much loss of range of motion, maybe a little bit less than 5 degrees.
Good. So grade 1, no, very little edema, very little hematoma. Both special tests will be negative.
Yes.
And range of motion is 5 degrees or less. Very good. What's a grade 2?
Grade 2 is moderate damage. You've got a positive for anterior draw and hematoma, but you have a negative for the talar toe.
And I don't know why, Eric. Did he hear?
And they might
No,
have
I didn't hear what you
All right,
said.
all right.
and they might have tenderness to palpation. You have a loss of range of motion of about 5 to 10 degrees and some edema. And then your grade 3 is maximal damage. You're gonna have a positive sign for anterior draw and talar and hematoma. You've got extreme pain to palpation. Your range of motion, you're gonna lose greater than 10.
Very good. So grade 3, all positive tests. Tons of range of motion loss, more than 10 degrees. 2 is only positive anterior draw, negative talar tilt. I don't know why anterior draw is positive and talar tilt is negative. I would just guess that anterior draw is a more aggressive test because you're actually drawing. Maybe that's why it's positive. And range of motion between 5 and 10. And grade 1 is very little range of motion issues, very little hematoma, negative special test. Very good. All right, the doctor asked, yes.
Oh.
I said I don't know why.
I'm
No.
joking.
You could ask the question if you want, feel free. No. The doctor asked that you recommend a nice ankle brace, and you look down in disgust when he mentions an air cast, which me and Carlos hate air casts.
Yeah. So our patient is a grade 2 officially, so what we are going to recommend is we're gonna say, we want you to do weight bearing as tolerated with a supportive assisted device. Those lace up ones are pretty good. There's a picture in the module.
Yes, the lace up is the best.
And that's good for edema.
I actually found this surfer in my module. He's like a world famous surfer, never heard of him. But they gave him the brace. It gives support, it also
Yeah.
stops the edema. It's much better than the
Yeah, you don't want them
Kelly
to do
Slater?
non-weight bearing.
Huh?
Then we
Kelly
talked
Slater?
about they
Some
can have
bald-
the
some blonde
DVT.
dude?
Bald or
blonde.
I don't know.
All right, very good. So you
Not a
you
guess.
guys are doing a really thorough job. It's
Yeah.
amazing. I'm impressed.
Thanks.
Now it's time to do some joint mobs to get some decreased pain, for example. What are the joint mobs you're gonna do?
We've got grade 1 and 2 AP glide to the towel roll joint.
And
we saw that earlier.
We saw that very well, so you have to know how to do the talocrural joint AP glide. Now, because it's a grade 2, when it comes to Therex, are you gonna do active or isometric?
We're gonna do isometric
Ah,
muscle
smart.
energy hold at,
Muscle energy, what is that?
at
Show
3
us.
points in patient's range of motion.
Show us that, please.
Oh, yeah, okay.
Muscle energy, it sounds fancy, doesn't it?
Sounds like it's gonna be great in soap notes and stuff. Muscle energy.
Muscle
5
energy.
minutes.
So we're gonna choose the, into dorsiflexion at 3 different points, so push against me and just hold it.
Wow, that
Don't
girl's
push
strong.
all the way through, alright, relax a bit. Push a little bit, there you go, so hold it isometric. Come a little higher if you can, okay, now hold it here, isometric, and one more time, further into the range, if you can.
Good, yeah, and
That's
you'll have to do
close.
this in inversion, eversion, dorsiflexion, plantar
And plantar
flexion.
flexion.
The reason why they're doing isometric because it hurts the patient to move. So now you're providing strength while they're not actually going through a full range. Very good. Now, what about that's? Did I miss something?
No.
Modalities.
Modality.
Oh, modalities. The patient, all right, so your patient requires electric modality to get rid of the inflammation or stop more inflammation, and you choose to use what?
High volt.
High volt. So there's 2 pads for high volt, one
Yes.
small, and the other one is how big?
Dispersive, and it's 2 times the size.
And you set up negative on the treatment area or
Yes.
positive on the treatment area?
Negative.
Negative on the treatment area. And is the patient's limb elevated?
Yes.
Yes, and you are setting the intensity to what?
Just before visible contraction.
Just before visible contraction. Very
And
good.
30 minutes every 4 hours.
Sounds good. All right. So now we're up to phase 2, and the patient is ready for active range of motion. What are some active range of motion techniques you could teach the patient?
So first we're gonna start with ankle circles. So she's gonna go clockwise 20 times and then counterclockwise.
The only thing I recommend is that position might hinder her movement. So I would have him be sit at the side of the table, or if you're gonna have it elevated, just make sure the ankle is not hindered. Circles, let's see circles. Oh, now how about clockwise, counterclockwise? I love it. And what's next?
Then we're gonna do ankle alphabets, cap letters.
Right. Having to do an alphabet is really goes through every range.
Writing cursive.
All right, very good. Now, as you all know, the Chinese doesn't have an alphabet. They are a character-based language. But we're not here for that. All right, now we're up to open chain ankle strengthening. Show us with the TheraBand how to do all the, and without, I don't like when the therapist, no, you're good.
Oh, okay.
I
I
like
was
when,
like,
I like when the
can I use my
therapist walks
towel?
away if need be. All right,
So she's gonna do plantar flexion.
show us resisted plantar flexion. This is TheraBand.
She's pulling at the band and